Welcome everyone to Raaonline. Today topic of discussion will be anesthesia for gastroschisis and omphalocele repair. So what are these conditions? These are basically congenital anomalies of the anterior abdominal wall. First we will talk about gastroschisis. Gastroschisis is a congenital condition where the baby is born with their intestines protruding outside the body through a defect in the anterior abdominal wall, which is lateral to the umbilicus. So there are a few differences between gastroschisis and omphalocele. We will go through that one by one. The important point is that this is a full thickness defect where the intestines protrude out parallel to the umbilicus. It's not over the umbilicus, it's paramedian. So this is the most important component of gastroschisis. So in this condition, immediate surgical intervention is required after birth. And with prompt and proper medical treatment, more than 90% of the children survive and can lead healthy lives. They may need follow-up throughout their childhood, but most of them survive this condition and they lead a healthy lifestyle. So basically, the components of gastroschisis is that it is a full thickness defect in the anterior abdominal wall and it is paramedian. It is away from the umbilicus, usually on the right side. It is lateral to the umbilicus. And it's usually the intestines that protrude outside the abdominal wall. Rarely we get viscera like liver or kidney protruding out, but those are very rare. Particularly, liver can be seen in up to 6% of gastroschisis. Otherwise, the other organs are very rarely seen in gastroschisis. So, as I have told, it's a full thickness abdominal wall defect. So, everything, there is a defect right from skin to the peritoneum. It's full thickness. The abdominal viscera extrudes into the amniotic space without amniotic membrane coverage. So, as I already told, the defect is usually on the right side of the umbilicus, and umbilicus insertion is spared, whereas in omphalocele, it is umbilicus insertion is not spared. So, this is usually an isolated congenital abnormality and it is not usually seen along with other chromosomal abnormalities. So, other chromosomal abnormalities are rare but can be associated with intestinal atresia, undecided testis and Meckel's diverticulum in up to 1/5 of the cases. Survival, as I have told, is more than 90% with proper intervention. In this too, the survival is more than 97% if the liver is not eviscerated. If the liver is eviscerated, the survival is less than 50%. Otherwise, it's almost like if immediate surgery is taken up, then survival approaches 100%. Coming to omphalocele, it's also called examphalous. So, it is not a full thickness defect. This is the most important difference between the gastroschisis and omphalocele. This is not a full thickness defect. The extruded abdominal contents are covered in a thin sac made of peritoneum, amnion and Wharton jelly. This is a midline defect. Umbilicus attaches to the sac. So, as you can see in this diagram, so this is the defect and as you can see the umbilicus attaches to the defect and this is a midline defect as opposed to gastroschisis, which is paramedian, usually on the right side of the umbilicus. Now, this condition is often associated with syndromes, named syndromes and chromosomal abnormalities like trisomy 13, 14, 15, 18 and 21. As I have told, it's associated with a lot of named syndromes like Beckwith-Weidman. This is important because this syndrome is associated with large tongue and retrognathia. So, you will face difficult airway in case with Beckwith-Weidman syndrome. Then Marshall-Smith, Meckel-Gruber and pentalogy of Cantrell are seen associated with omphalocele. So, since this condition is seen along with other chromosomal abnormalities, it has a high incidence of cardiac defects like ASD or tetralogy of Fallot, and it's usually associated with stillbirth. The survival usually is only less than 50%, even with prompt intervention. This is because of the associated defects.